So good morning, everyone. I'm JoEllyn, one of the electrophysiologists at the Minneapolis Heart Institute, and I've been given the opportunity to speak on arrhythmias in pregnancy with Dr. Carter this morning. I joined the Cardio Pregnancy Consortium about 6 years ago, and our patient population continues to increase with every passing year. Every week, I get 2 to 3 referrals for a pregnant patient with an arrhythmia. And I hope that this will shed some light on the topic that seems to be an area of extreme discomfort for most providers. I have no disclosures relevant to this talk. In the next 20 to 25 minutes, I will try to give some conceptual background of this topic and get into specifics with the help of some cases. Ultimately, I hope to give you an approach to managing this population and to starting an evaluation prior to seeing our team, which sometimes can take a little bit, although we try to get them in quickly. I'll speak briefly on the morbidity and mortality of pregnancy, some of the hemodynamic changes during pregnancy, the management of the most common arrhythmias, briefly touch on device management, special populations in this topic, anticoagulation, and reintroduce you hopefully to our cardio pregnancy team. So you can see on this graph that deaths in pregnant patients are increasing, and here we have between 2018 to 2020, and they're increasing, and that the United States maternal mortality rate exceeds that of other high-income countries, and you see the United States up here in this top line. Maternal mortality is defined here as death of a pregnant patient or death within 42 days of termination of pregnancy. The exact causes for this increase are unclear, but some of the reasons that have been proposed include the following. One is the possibility that the COVID-19 pandemic has challenged health systems across the world and limited patient access to care. 2, the US has an overall shortage of OB providers relative to the number of births. 3, access to home visits after delivery varies in the United States, but is guaranteed in other countries. And 4, the US is the only high-income country that does not guarantee paid leave to parents after childbirth. I'm sure there are many others, but those are just a few to consider. Of particular concern is that the mortality rate in pregnant patients is exceptionally high for Black patients, who, as you can see, suffer more than double the average mortality rate and nearly 3 times higher rates compared to rate for white patients. Cardiovascular disease is the most common cause of indirect pregnancy-related mortality and affects 1 to 2% of pregnancies. The reasons for this include increased age with first pregnancy, as we're seeing, and a rising number of patients with cardiovascular risk factors such as obesity, hypertension, diabetes, as well as a growing population of patients that have congenital heart disease or other structural heart disease. Given the overall mortality rate of 17.4 patients per 100,000 live births, more than half of all pregnancy-related deaths were caused by disease of the circulatory system, as you can see from this slide. The exact contribution of arrhythmias to this rising mortality is unclear, because arrhythmias are not analyzed separately from other cardiovascular etiologies in the pregnancy mortality surveillance system. However, the incidence of arrhythmias during pregnancy has also been reported to be increasing. And that, as you can see here, this is a little bit older data from 2000 to 2012. And this has been primarily caused by increased incidences of atrial fibrillation on the top line and ventricular tachycardia. Cardiac arrhythmias occur more commonly among patients with underlying congenital and structural heart disease, with rhythm disturbances affecting 5 to 9% of those pregnancies, which is very high. As you can see, patients with arrhythmias suffer significant morbidity in terms of maternal and fetal complications that correlate with these diagnoses. Many of you may all have seen or may be familiar with the WHO classification for pregnant patients. This was, interestingly, derived from a consensus statement that was published in 2006, which proposed risk classification of pregnant patients by medical condition that is still used today. This risk classification integrates known maternal cardiovascular risk factors, including underlying heart disease, and this table stratifies risk based on arrhythmia type, but there are other such tables that include varying forms of structural heart disease. In our cardiopregnancy assessments, we include WHO class as part of our summary and recommendations, which can be used to track outcomes of our population and provide anticipatory guidance to patients. And you can see here with increasing WHO class, you start with sinus tachycardia, sinus bradycardia, isolated PACs, which really don't confer any significant increased risk. They're very infrequent PVCs. With increasing risk, you get supraventricular arrhythmias that have a small increased risk of morbidity and mortality, and we're seeing these patients at least once per trimester. And patients with ventricular arrhythmias, as you can imagine, have a significantly increased risk for maternal mortality or severe morbidity, and we're seeing these patients even more frequently. Going back to basics, and needless to say, there are a tremendous number of physiologic changes that occur in pregnancy. The heart rate increases 10 to 20 beats per minute, reaching a maximum in the third trimester. Cardiac output increases by up to 50% compared to pre-labor values. And these changes begin to resolve within the first 48 hours. Most changes resolve within 2 weeks, but it may take as long as 6 months to see a full return to baseline. And as you can imagine, some patients with structural heart disease prior to pregnancy never return to baseline. As a result of these physiologic changes, pharmacokinetics also change. Delayed gastric emptying and mobility and motility, increased plasma volume, fat accumulation, increased volume of distribution, decreased albumin and plasma-binding proteins all affect drug distribution and clearance. As a result of these changes commonly result in reduced pharmacologic effect of the drug. So in other words, you need to use a higher dose of a drug than you would expect. And here you are trying to use a small dose as possible in this population. As you can imagine, few studies have directly studied the properties of cardiovascular drugs in pregnancy in a randomized control fashion. In the 1960s, the teratogenic effect of thalidomide in pregnancy appropriately resulted in heightened public concern about the use of medications in pregnancy. In 1966, the US FDA issued a requirement for animal studies for drugs, and in 1979, they introduced a 5-tier set of alphabetic categories, as you see here, to designate the safety of the drug during pregnancy, and these we're probably all somewhat familiar with. That system was used to guide clinicians and patients on the safety of drugs during pregnancy for over 35 years until the FDA replaced those categories with a narrative labeling system in 2015. Maybe you all have started to see some of these if you've looked up certain drugs for use during pregnancy. The new labeling rule provides updated information when it is available to help clinicians explain the potential benefits and risks for pregnant patients, fetuses, and breastfeeding children, and includes sections on pregnancy, lactation, and the use in females and males of reproductive potential. There's a very comprehensive review of cardiovascular medications in pregnancy written by Halperin and colleagues in 2019, which I strongly recommend reading, which lists many common medications that may be used in patients who may become pregnant. And you can see, and this is just an example, for many different medications, it will list safety in pregnancy based on consensus. Now the former FDA categories, safety in lactation, and also some information about recommendations for fetal use. When it comes to cardiac rhythm management in pregnancy, this is really a core slide that summarizes the most commonly used medications along with their safety. And as you can see here, adenosine, metoprolol and propranolol, digoxin, lidocaine are all fairly safe and thought to be okay to use in pregnancy. Amiodarone, on the other hand, is thought to be relatively contraindicated unless absolutely required. And drugs like sotalol and flecainide have limited data, but can be used with caution. So next, in order to highlight some of the most common arrhythmias we encounter in pregnancy, I'm going to run through a few cases. So our first case is a case of palpitations, and I'll say that these are drawn from some of my experiences. So Ms. Smith is a 30-year-old female with past medical history of paroxysmal atrial fibrillation who is 8 weeks pregnant. She has not been seen by cardiology in 3 years, of course, and she notes to her OB a history of prior ablation and was told that she was cured. So she calls in surprised with increased palpitations. In addition to an appointment with cardiology, you recommend A, an ASAP echo and EKG, B, a monitor to quantify palpitations, and you make sure it's a real-time monitor so you can get those data as soon as possible. C, start warfarin, gold INR 2 to 3, or D, start weight-based enoxaparin. So the answer here is A and B. Of course, any patient calling in with palpitations, even before you get them into a cardiology appointment, please do try to get as soon as possible echo and EKG. And the point I'm trying to make here is to please order a monitor that is a real-time monitor. We have a couple of options for monitoring, but one involves wearing a patch that is sent back, analyzed, and then comes back to us a couple weeks later. There's also a real-time monitor that we happen to use, the ZOAT, for our practice, where you can actually get that data immediately if they have an abnormal rhythm. And you can imagine if it's a pregnant patient, time is of the essence, since we have limited time to intervene if we need to. So Ms. Smith had an echo and an EKG that were both within normal limits with a resting heart rate of 70. Her 7-day monitor demonstrated 2 episodes of atrial fibrillation that were 5 to 6 minutes long, but pretty fast, average heart rate of 140 beats per minute. She is now 12 weeks pregnant. You see her in clinic and recommend A, metoprolol, B, flecainide with metoprolol, C, warfarin, but a goal INR 2 to 3, or D, watchful waiting. I don't know if you all think about what you might do. But I would say in this case, you have some options based on shared decision-making with the patient, how symptomatic they are, how frequently they're perceiving their symptoms. Overall, of course, with atrial fibrillation, we're looking at stroke risk, and because this patient is young and has no other comorbidities, there's no need for anticoagulation. And generally, we're not going to be starting warfarin de novo during pregnancy because you don't know how much they will require to be therapeutic. Watchful waiting would be very reasonable. Metoprolol is safe, and flecainide would also potentially be safe, particularly now this patient is in their 2nd trimester. So our case 2 is an irregular heartbeat. Ms. Doe is a 35-year-old female with past medical history of type 1 diabetes and low burden PVCs, who is now 7 weeks pregnant and calls in with increased symptoms. In addition to a cardiology appointment, you recommend A, an ASAP EKG and echo, B, a 24-hour to 48-hour Holter monitor, C, start aspirin 81 milligrams daily. And here, all 3 would be appropriate. Of course, EKG and echo, as we mentioned. In this case, a 24 to 48-hour Holter monitor would be very helpful, and I'll just mention that our hospital does our own Holter monitoring, and we can get that data back very quickly. So this is a very helpful kind of monitor to order in a patient who's having frequent symptoms like PVCs, and you just want to quantify them quickly. Starting an aspirin 81 milligrams daily would be reasonable in this patient, not because of their PVCs, but potentially for preeclampsia prevention. So Ms. Doe had an EKG with normal intervals and a heart rate of 80 and occasional RVOT PVCs. She had an echo with a normal EF and a 24-hour Holter with 10% PVCs and no VT. You see her in clinic, by now it's 13 weeks, and you recommend A, metoprolol, B, start flecainide, C, watchful waiting, or D, follow up 2 months post-delivery, no big deal, you're fine. So I would say to start A or C would be reasonable. Often metoprolol doesn't fully suppress the symptoms, but it's usually something that we're trying, and this person is in their 2nd trimester now, and so if they're still symptomatic despite metoprolol, flecainide at a lowest dose that is effective would be reasonable. But if the patient is really not all that bothered by it and they really want to wait it out, watchful waiting would be reasonable. But in terms of ongoing follow-up, I would say very short-term follow-up with an echo and a monitor in another month or 2 just to re-quantify how things are going. Case 3 is a case of fluttering. Ms. Hill is a 38-year-old female with past medical history of anxiety who calls in with a sensation of heart fluttering. In addition to a cardiology appointment, you recommend EKG, echo, real-time monitor, or TSH. Of course, she has a history of anxiety, so your pretest suspicion is that it's probably all just anxiety and panic attacks. So all of these would be appropriate, but in this case, not surprisingly, a standard monitor, a ZEO monitor, was ordered, which returned 3 weeks later. And this is what it showed: a wide complex tachycardia that was sustained and went on for minutes at a time. So you see this tracing and you recommend A, urgent outpatient appointment to discuss next steps; B, start metoprolol, 25 milligrams twice daily; C, start amiodarone; or D, admit to the hospital for further management. And in this case, this patient was added urgently to my schedule, and I subsequently admitted them. Ultimately, they had a cardiac MRI without contrast, which is a reasonable approach even during pregnancy, and this demonstrated ARVC. She was started on sotalol, which did suppress her arrhythmias, and had a subcutaneous defibrillator placed in order to minimize fluoroscopy. And here is a X-ray showing just what it looks like, a subcutaneous defibrillator. Of course, this was not from our patient. We did not get an X-ray to document the position. But this is the lateral axillary line generator, and then the lead tunnels just under the skin. So thankfully, again, this is something we can do without fluoro. So for the interest of time, to also let Dr. Carter present, I'm going to skip to my last case here. And that is a case of slow heart rates. Ms. Block is a 23-year-old female who is 21 weeks pregnant, who has a history of congenital heart block. Of course, she only presents at this time, hadn't seen cardiology in quite a long time, but thankfully she's overall feeling well without exertional symptoms or lightheadedness. In addition to an appointment with cardiology, you recommend an ASAP echo, an EKG, 24-hour Holter monitor, ask her to exercise while wearing it to see what her heart rate response is, and a TSH. And of course, the answer is all three. Here is the EKG obtained, and here you can see sinus rhythm with complete heart block and a junctional escape, roughly 43 beats per minute. So quite slow, but a narrow escape. So that patient presents for an in-person appointment after having had a 7-day monitor retrospectively, with an average heart rate of 42, max heart rate of 64, longest pause of 3 seconds. And the echo was normal, and thankfully she is still completely asymptomatic. So you recommend watchful waiting, emergent pacemaker implant with limited fluoroscopy, or delivery at a tertiary care center with electrophysiology available. And I would see that A and C would be the most reasonable here. Since the patient is asymptomatic, there's no need for a pacemaker, although it would be possible to place it with limited fluoroscopy if needed. And this is just a summary of the guidelines for congenital complete heart block, essentially showing that in this particular patient, because their average ventricular rate is less than 50, they probably would have been a candidate based on 2A recommendation for a pacemaker before pregnancy, although presumably shared decision-making had been taking place all along with regard to that. Briefly about device management during pregnancy and delivery, please make sure to get routine device checks. Always, we're going to want an echo and an EP or cardiology appointment at some point during early pregnancy for someone with a device. Magnet is helpful if there's going to be cautery used during delivery, but make sure that if that cautery is used, that the patient is on a monitor, as tachytherapies will be inhibited. No telemetry monitoring is needed during delivery unless there's evidence of an unstable rhythm. Just a couple populations that are of particular interest in this area. One is the congenital or advanced structural heart disease population, and ideally in this case we want preconception counseling. The same thing for hypertrophic cardiomyopathy, who also has a significant increased risk for arrhythmias during pregnancy. Congenital long QT is another area and another problem that we encounter. Many times these patients are already on a beta blocker, and if they're on Nadolol or propranolol, that is something we typically continue. If they're on atenolol, we're stopping that because it is contraindicated in pregnancy. And in general, if they're stable on one of the medications that has been successful for them, we'll keep it. but sometimes we'll try to get them back over to propranolol or nadolol. Brief mention of anticoagulation in pregnancy. Ideally, again, we're preconception counseling these patients about how to approach their anticoagulation. A warfarin dose of less than 5 milligrams per day is thought to be safe in pregnancy, but we switch them to low molecular weight heparin if they have a higher dose. And then we switch them back to low molecular weight heparin at 36 weeks if they are on warfarin during pregnancy. That switch happens in the hospital if they have a mechanical valve to avoid valve thrombosis and low therapeutic levels. And just remember that reversal of anticoagulation in a patient that is pregnant does not equate to reversal in a fetus. And usually cesarean is recommended if a patient is fully anticoagulated to reduce the risk of fetal trauma or intracranial hemorrhage. And remember, DOACs are contraindicated. So in summary, arrhythmias can cause significant morbidity if they occur during pregnancy and should be addressed quickly. Expedite evaluation of patients, please, by at least ordering some of the initial tests, and use Holter and real-time monitors for these patients if at all possible. Please reach out to our cardiovascular OB team providers directly for any referrals. And this is a non-inclusive list of our team. Thank you for allowing me to provide a whirlwind tour of arrhythmias. I will now hand the podium over to Dr. Carter, who will talk about the management of fetal arrhythmias.
Thank you very much for having me this morning. I'm Chris Carter. I'm one of the 2 electrophysiologists over with the Children's Heart Clinic in Children's Minnesota. I have the privilege of also working over here with our adult congenital program, and have been doing so for any number of years now. And I will be talking about cardiac arrhythmias in pregnancy, and in this case, the caring of both patients is the fetal patient, and considerations for caring for both when there is a fetal arrhythmia. I have no disclosures. Basically today, the goals are to review the most common fetal arrhythmias that we run into in their evaluation, the decision-making process in determining which medications we will use or if they're even needed for the treatment of these arrhythmias, and then ongoing studies in fetal arrhythmias. The reason I would say the ongoing studies are very important is the vast majority of information we have right now is based on observational studies, historical studies, and very little in terms of real prospective RCT or additional information. So a lot of consensus is basically what we're using in terms of how we approach this. And as a consequence, management can actually change institution to institution depending on who's driving the decision-making. As a general background to the fetal heart, the conduction system in the fetal heart is functionally mature by 16 weeks of gestation. As expected, the normal fetal heart rates are going to be faster than a older child or adult, and normal fetal heart rates are in the 110 to 160 range. And fetal arrhythmias only affect a small portion of pregnancies. In terms of the arrhythmias that we run into, the vast majority of these are just going to be isolated ectopy, usually PACs. So PVCs are very rare. PACs can be a bit of a confounder, and we'll talk about that in a little bit when determining whether there's something more significant going on. The second most common group of arrhythmias that we run into are supraventricular arrhythmias, particularly SVT and atrial flutter. And the third large group of patients that we have to deal with fetally are congenital heart block patients. There are a smattering of other additional things that we can run into, but they're exceedingly rare and won't be part of the talk today. So we'll go through just a couple cases, and these are real cases followed by our fetal team. So the first is a 28-year-old G4P1 at 21 weeks gestation. She's presenting for fetal bradycardia and an irregular rhythm when seen by her OB for a routine exam, and was subsequently referred to fetal cardiology for further evaluation. When we're evaluating fetal arrhythmias, basically the only tool we have is fetal echo. There are some advanced studies that people are working on, such as magnetofetal electrocardiography, but generally speaking, those are not widely available. So through various methods, including M-mode and various Doppler views, that's sort of the best tool we have for evaluating rhythm, and this is an example of an M-mode where we're looking at the rhythm. And so on the top, and this can change depending on fetal position, but in this case, the top is the atrial, and the bottom is the ventricle, and you can see sort of AV timing here. So atrial contraction, ventricular contraction, atrial contraction, ventricular, and then an early atrial beat here with no ventricular response. So this would be a pretty typical view you see for a blocked PAC, which is why these are often presenting as bradycardia in the fetus. About half of newborns actually have PAC, so again, they're very common and related to an immature myocardium, and they can occur as early as 15 weeks, but mostly we see them as patients get closer to delivery. The reason they're a confounder is sometimes these patients can present and there can be concern for congenital heart block. So if you're an atrial bigeminy with blocked beats, it can look like an AV block, but when you evaluate timing, you'll actually see that it's an early A that's blocked. So this is very similar to that other picture, except now it's reversed because of fetal position with the atrium on the bottom and the ventricle at top. If it was really heart block, the atrial rate should be fairly steady and the ventricular rate should be fairly steady with no communication in between. So determining whether it's blocked atrial bigeminy or heart block is an important thing to do when evaluating, but is sort of the main reason that we care about PACs prenatally. Otherwise, they're generally benign. They don't require any therapy, and the vast majority of the time, they're going to resolve on their own, oftentimes before delivery, but certainly after delivery, within a couple of months, they usually go away. So case study number 2. This is a 34-year-old G4P2012 at 27 weeks. She was referred to MFM due to IUGR, or intrauterine growth restriction, and echogenic bowel. When evaluated by MFM, they noted an abnormal rhythm, and they referred to cardiology for further evaluation. On echo, this is a Doppler view. So at the bottom, you have the aortic outflow, and at the top is an innominate vein tracing, and with contraction of the atrium, you get a little reversal of flow in that innominate in the fetus. And so this is showing you a very tight VA timing, so a short RP, and then integrate conduction down to the VA again. So this is consistent with SVT. And then, keep clicking in the wrong place. And this is just another view with mitral inflow and LV outflow showing you the same thing. But with this one, they were able to capture the termination of SVT. So again, you can see a short VA timing when in SVT, and it breaks antegrade, and you have a return of normal sinus rhythm with A and B here. So these are kind of the tools and the views that they use when evaluating fetal SVT or fetal arrhythmias. SVT in a fetus is considered incessant or paroxysmal episodes greater than 180 beats per minute. About 10% of the fetal arrhythmias we're seeing are SVT of some form, and a small number of those are associated with congenital heart disease. The vast majority of SVT that we see in a fetus or even newborns are in totally structurally normal hearts. The most common form we see are AVRT, or AV reentrant tachycardias. And we actually see atrial flutter not uncommonly prenatally and postnatally when we're discussing supraventricular arrhythmias. There is associated fetal morbidity and mortality. Fortunately, mortality is low when treated, but morbidity can be significant depending on how difficult it is to control, as well as consideration for the mother and morbidity related to medications. So just as a review, the more common form of SVT we see, as I said, is AV reentrant tachycardia. It's a pathway-mediated tachycardia, so accessory pathways. Usually conduction is antegrade down your normal system and retrograde back up the accessory pathway to complete the circuit. Obviously, prenatally, you can't do an EKG and see WPW, but about half these kids do have WPW postnatally when you can get an EKG after delivery. The other form we see, atrial flutter, again, circuit at this point is above the AV node, normally with variable conduction, so 2 to 1, 3 to 1. Fetal flutter can be very fast, even up to 500 beats per minute, just because of that smaller atrium and the smaller circuit. And unfortunately, we almost never see one-to-one conduction prenatally. And this is usually a typical flutter. Unlike adult flutter, postnatally, usually if they're still in flutter or present in flutter after birth, they just require cardioversion and never require therapy again. So it's sort of an isolated finding when you're able to address it postnatally. So really, what we're concerned about, and sorry, this is just a picture of atrial flutter, which is impossible for probably most of you to see, but it's that same M mode. And what this is showing you is a very fast atrial rate with 3-to-1 conduction, or I mean, sorry, with 2-to-1 conduction and then 3-to-1 conduction on the bottom. Complications that we're mostly worried about, one is decrease in function. So, fetuses and infants are sort of that one group of patients that can go into an AV ventral tachycardia and stay in for weeks. And they can start to develop issues with a tachycardia-induced cardiomyopathy. They begin to have progressive dilation, and then they begin to have issues with AV valve insufficiency, which just sort of furthers the whole process. So one of the things we're looking at here, if that goes untreated for long enough, fetuses begin to develop hydrops, so extra fluid both in the tissues and around the organs. So you can see fluid in the abdomen, fluid around the lungs, and significant fluid in subcutaneous places. And that is a sign of later heart failure in a fetus. So therapy for these patients is as Dr. Moore alluded to, difficult because we are limited in the medications we can use, and that limit is really due to what crosses the placenta. So all patients, when we're initiating therapy for a fetal arrhythmia, are admitted to the hospital for close monitoring of both mother and fetus. It's a multidisciplinary care team that participates in the care of these patients. So MFM, adult electrophysiology, is usually brought in to help us monitor the mother in terms of potential complications with the arrhythmia, with the antiarrhythmics that we're using. Pediatric EP we're more in the background when patients are over here, but we do see the patients over in clinic when they are coming in as an outpatient or for difficult patients prenatally. Fetal cardiology is involved to continue to follow the heart, and our fetal team guides a lot of the therapy in this institution for our fetal patients, and any other additional specialists that are needed, either due to complications from medications or other maternal comorbidities. Once they are able to be discharged, they are followed closely by MFM and fetal cardiology for any changes or possible needs for readmission to adjust what we're doing. The goals of therapy when we're treating fetal SVT are either to avoid hydrops from developing or reverse it. So fortunately, like other tachycardia-induced cardiomyopathies, it is a reversible process if we're able to get the rates under control. Ideally, rhythm control is what we're aiming for, but if we're able to bring those rates down into a more normal range for an infant, again, sort of, get the rate to 140, 150, that can often be enough. So sometimes for flutter patients, that's the goal. We want a stable mother and fetus within acceptable monitoring parameters based on the medication that we're using. And the goal is to get to term or as close to term as possible. In extreme cases, if we're having significant difficulties and we're not able to get the fetus better, we will sometimes consider early delivery, but in-mom is the most stable place for the fetus. They're essentially sort of on a bypass. So if we can get them to term, they're going to do better in terms of avoiding other comorbidities associated with prematurity. So drug choice, we really have a very, very limited armamentarium when it comes to transplacental transfer of the drugs. Digoxin basically has the highest transfer. Flecainide and sotalol also have a reasonable transplacental transfer when deciding on therapy. For the reasons that Dr. Moore alluded to, dosing is often on the higher side to account for getting acceptable fetal levels of medication, in addition to the changes that happen during pregnancy with mom. The maternal risk factors can also affect our choice of medications. So if there are any existing issues, QT prolongation, conduction abnormalities, significant bradycardia, if mom is on other medications which may interact with what we need to use, or if there are electrolyte abnormalities related to other things going on with pregnancy, can all impact what we're choosing. And then the fetal condition impacts as well. Hydrops does affect the transplacental rate of transfer of medications. So in sustained SVT without hydrops, our first-line therapy historically has been digoxin. So this is sort of the old school approach. We don't have any great trials at this point in time to guide change, but anecdotally, people are moving over to flecainide as a first-line agent. There are a few small studies out of single centers that at least seem to demonstrate that it's potentially a little bit better than digoxin. And our practice here has actually been to move over to flecainide as a first-line drug for therapy. Second-line therapies often involve adding in digoxin, so using 2 medications at one time. Or for SVT without hydrops, sotalol is also a medication that has some use. We will usually give 3 to 5 days on a medication before deciding on a change. If we're on a medication and see some improvement in rate, but not cardioversion, we will often push up on the dose. If we're really seeing no effect in 3 to 5 days, then that's often when we'll either add in a second agent or change the agent that we're using. Third-line therapies, for sustained SVT, as alluded to earlier as well, is amiodarone. I can only think of 2 or 3 times in the last 10 years that we've had to get to amiodarone as a medication. And the main reason we try to avoid it is thyroid issues in both mom and infant. Another option, and I don't think we've done this here yet, you can actually give intrauterine digoxin or direct fetal IM digoxin as sort of a last-ditch effort to terminate SVT that obviously has some additional risks for both the fetus and mom. With hydrops, digoxin's not in line as a therapy because of how much hydrops affects transplacental transfer. So again, flecainide is the first line here. You can add in digoxin as an adjunct, or again, sotalol and the other therapies as we just discussed. Atrial flutter is a little bit different. So our first line therapy there would be sotalol. And then again, sort of the other second line agents that we can change to as needed. But sotalol is the first line therapy for atrial flutter. Again, really the main consideration a lot of times when we're starting this beyond getting control of the fetal rhythm is closely monitoring mom. Because again, she's the one that's going to be having the higher drug levels. She's the one who's going to have side effects if they're really going to be present. For digoxin, all patients get an EKG and electrolytes drawn. You can do an IV or a PO load, and we really aim for a goal level of about 2.5 when we're monitoring these patients, so sort of a higher dose. And while in-house, we're usually getting daily EKG and electrolytes to be sure that we're not going to run into issues, especially with hypokalemia or hypomagnesemia. And then EKG, mostly watching conduction and making sure we're not going to start causing issues with AV block. Flecainide, we get a baseline EKG echo and electrolytes on mom. The echo is to make sure we're not dealing with a situation with decreased function, given the increased risk with flecainide. And again, the starting dose is higher than you would normally use on an outpatient basis at 100 to 150 BID. The goal, the levels are 0.2 to 1. And basically, it's EKG monitoring while in-house. Sotalol, likewise, EKG and electrolytes. Starting dose is a little bit more regular, 80, either BID or TID, in daily EKGs. As I mentioned with amiodarone, the main concern is additional thyroid testing. Amio is a little bit different when we're using it. So like I said, most medications we're giving 3 to 5 days. Amiodarone, just based on its pharmacodynamics and how it loads, you actually give up to a week before declaring it a failure. So that can take a little bit longer. Additional monitoring, fetal echo is usually done at least on admission. It can be done daily, especially in a hydropic fetus. If the fetus is otherwise well, a lot of times they'll just do one before discharge. And again, MFM helps us in monitoring the general health of the fetus with biophysical profiles as well. There is currently, and this is the first prospective RCT being done for SVT, it's called the FAST trial. Basically, it's using the medications we use in 3 arms, and is currently ongoing. So we're a participant here at this center, and unfortunately, we probably still won't have useful information for quite some time, but at least we're going to have some. And this has been a historical issue in pediatrics, is we just don't have great multi-center trials just because of both the patients that we're treating and just the small numbers of patients. So our third case study, and this will be the last one, is a 35-year-old G2P1 at 31 weeks who presented to an outside hospital with decreased fetal movement, referred to MFM for a second opinion, and found to have bradycardia, and subsequently referred to fetal cardiology. So this is a patient with complete heart block, and you can see on both of these, so on that first one, the V is at the top, the A is at the bottom, and as opposed to PACs, you can see the atrial rhythm is very regular, the ventricular rhythm is very regular, and they are completely dissociated. Great, these loaded out of out of line here. And then basically this is just another view using inflows outflow of the aorta and innominate vein tracing to again show you the same thing. The majority of congenital complete heart block is immune-mediated. So the fetal heart is structurally normal, but mom has antibodies, SSA and SSB. So most commonly seen in lupus or Sjogren's. So about 2 to 3% of pregnancies will have maternal antibodies. Unfortunately, 1 to 3% will get heart block. So it's a small number. 20 to 30% of the time, mother is aware that she has a clinical disease. So that means the majority of our patients aren't even aware that they have some form of autoimmune disease. It does cause a general myocarditis or inflammation in the fetus, but it preferentially affects the conduction system, which is why we see heart block. But infants can be born with a more global picture of myocarditis with decreased function. They can also have what we call neonatal lupus with a lot of other organ system involvement, in particular rash. Mortality rate is 11 to 29%, and that's both prenatal and postnatal. About 20% of those do have that more global involvement. So it's a significant issue. And unlike your patient, the majority of these patients that are brought to term will receive a pacemaker sometime in childhood. That can be before leaving the hospital as a neonate, all the way up to late adolescence, early adulthood before meeting criteria. We can also see heart block related to congenital malformations. These are essentially patients who have L-looping to their ventricles. So left atrial isomerism is a form of heterotaxy, often associated with very complex congenital heart disease, or congenitally corrected transposition. And these are sort of classically L-looped ventricles. When it's congenital malformation, there's nothing that we can do prenatally to help with that, just because it's actually due to an anatomic abnormality in how that conduction system developed, as opposed to an immune-mediated heart block, where we are hopeful one day will make a significant impact. So any number of things have been tried as preventative strategies. So these are obviously in patients where they have known antibodies or previous pregnancies with immune-mediated heart block. People have tried maternal plasmapheresis twice a week, which has not made an impact. Transplacental IVIG, which has not made an impact. Early monitoring, so this is the PRIDE trial where they did weekly echoes for incomplete AV block and subsequent treatment, which unfortunately didn't make a difference. People have tried just prophylactic steroids with dexamethasone, which also hasn't made any difference. The one study that has helped to some degree is preventative hydroxychloroquine in mom. And we have tried this a couple of times here. So these are SSA positive moms who with previously affected offspring, and it was started very early, so prior to 10 weeks gestational age. There was a 64% decrease in the recurrence rate of heart block, but still some patients did have heart block. In terms of more conventional therapies, after heart block has developed, there's really nothing that we can do. It's an irreversible process. And the reason early monitoring has been difficult is this can happen quite quickly. So in under 12 hours, a fetus can have normal conduction and then have complete heart block. So there's a very limited window in some of these patients in which we can try to intervene. If you are able to pick up either first or secondary AV block or some change on the echo, steroids is really the first line therapy and is what is tried most often. Obviously, high-dose steroids carries risk to mom as well in terms of blood pressure or blood sugar management, and these are obviously issues which can also be affected by pregnancy. If there's additional cardiac disease, IVIG is often used. That's a 70 milligram IV dose times 1. If heart block has developed and the fetal bradycardia is significant, terbutaline is a medication that we use to try and increase the fetal heart rate. We actually have one patient right now who's on terbutaline. Generally, this is in patients that either have exceedingly low heart rates, so less than 55 beats per minute, or in patients where there has been some development of heart failure and high drops to try and reverse that. And oftentimes we'll use terbutaline with a goal to get mom's heart rate between 110 and 120 beats per minute. We don't really try to push further than that. There is, I think this is the only ongoing trial right now for congenital heart block, which is the stop block trial. So this is a variation on monitoring, but it uses home monitoring in addition to weekly echoes. And the home monitoring obviously isn't for bradycardia. If you get to that point, it's probably too late, but more for irregular heartbeats. So kids that may have, some fetuses that may have potential early signs of second-degree AV block. And they do 3 times daily home checks and weekly in-office echoes. And again, if we're able to detect this early, high-dose dexamethasone or IVIG, as discussed earlier, are what we use. And the primary outcome of the study is really the percentage of patients who do present with secondary AV block who have normal sinus rhythm at birth. And that is congenital heart block. And that's all I have for you. So thank you.